Welcome to the AQA YouTube channel. To navigate through the video, you can select specific chapters or subjects of the video. Enjoy watching and remember to subscribe.
Okay, so welcome everybody. This is probably our last online session for the year, for 2021. We started these sessions back in 2020 and they've been very popular, as is this one today on spasms and rigidity. I'd just like to welcome you all and begin the formalities by acknowledging the traditional custodians of the land on which we meet and live and work and play. Where I am is the Wurundjeri people, and I'd like to pay respects to their people, their culture and traditions. I'd also like to pay particular respects to their elders, past, present and emerging, and to any First Nation people that are joining us today. So without further ado, I'll hand you over to our MC Erdem from AQA, and he will lead our wonderful panel of experts who've given up their time today to discuss this topic. So over to you, Naz.
Thanks very much, Sal. I just want to start with thanking Andrew Nunn, who's with us as well, and also Rebecca. Andrew Nunn, many of you guys might know Andrew. He's the director at the Victorian Spinal Cord Service at Austin Health, and Rebecca is a physio at Neuro Rehab. And on top of that, we've got other special guests as well, Emily, Josh Hose and Geoff. And of course, some of you guys might know us as well. We've all got spinal cord injuries. Might go around and do a quick introduction. Just let people introduce themselves, in a few seconds, and we'll open up from there. Andrew, can we start with you, please? Like I said, many people do know you, and I'm sure you know many of the participants who we can't see at the moment, but I'll tell you, there's a lot of people in there that went through Alfred or Austin Health.
Look, I work in the spinal unit, but I've actually worked overseas in Canada in spinal, and also had a lot to do with the Alfred. So like Rebecca, I think I have a fairly eclectic view of spasticity. And we see it in stroke, obviously, and other things as well. So, I just welcome people to ask questions, really. That's how I do it.
Yeah, no, thank you, Andrew. Now, over to you, Rebecca. I mean, did you want to add, I've done a quick introduction, and I know we're going to start with, you're going to give us a quick presentation. Maybe you want to mention that as well.
Yeah, sure. Yeah, so I'm Rebecca Grenfall. I'm a physiotherapist at Neuro Rehab Allied Health Network. I work out of Werribee and Deer Park. But yes, look, I've just been asked by Emily to come on today to have a chat with you guys, I guess, a little bit more about spasm and spasticity and tone, and working through that, getting a bit of better understanding, and I guess seeing all the options that are available for looking at management options. So yeah, we can definitely have it quite informal, as Andrew said, but I thought it might be nice to just have a bit of a run through again, making sure everyone has a bit of an understanding of, I guess, what the differences are and how we can help you support you in that area.
Thanks, Rebecca. Josh, do you want to do a quick introduction of yourself and, when you hurt yourself, what level of injury you've got, and that's it. And after that, we'll touch on our issues we've got with spasm and rigidity.
Yeah, no worries. So yeah, Josh, Peer Sport Coordinator at AQA. I had my injury back in 2005. And fun fact, Naz, Andrew was actually the doctor that came through and saw me at ICU. So there you go. There's the longevity of it all, 16 years ago. And so yeah, I was involved in a car crash and dislocated my neck and become a C6, C7 incomplete quadriplegic. And I think it'll be interesting to discuss today, Naz, I guess my journey of spasms and rigidity. Early on, for my functional capacity, I guess I found the spasms a bit limiting and somewhat dangerous with transfers. And then over time, as I got a bit fitter and stronger, I guess I learned to adapt them to suit my daily living. So yeah, maybe we'll throw
that's right. Thanks, Josh. And we'll talk about how we can take advantage of our spasms as well, because spasms can be a negative thing, but they can also be a positive thing. Emily, over to you.
Hi, my name is Emily and I was injured in 2018. I'm an T4 and I have had really bad spasms, but I've gone down the route of trying not to have medication and trying to help manage them through physiotherapy and stuff like that, and it's worked for me. And yeah.
Excellent, thanks, Emily. Geoff, over to you now.
Hi there, my name is Geoff Dossetor. I had an accident when I was working in New Zealand about 20 years ago. I'm C4-5 quad, and I've never taken any medication for spasm. And I'm sort of coming from that perspective. And I did attend something called Project Walk, which I don't think exists anymore, but it was in California, where they tried to encourage spasm and try to use it for functional use. But I only got to spend a month there. But other than that, just learned to cope with my spasm, and it's not all negative. Sometimes it can be a positive as well.
Very true. Thanks, Geoff, for that. I didn't do an intro of myself. So my name's Naz, everyone. I'm a C6 quad. Broke my neck diving into shallow water back in 1990, the good old days. And I've had issues with spasm along the way too. And it is one of those things where, you know, if you can make it work for you, you do. And, you know, sometimes, of course, it's a negative and you just want it to stop. So we'll talk about what we can use if we want to reduce that spasm, including activity and also medication as well. So, Rebecca, you're going to do a short presentation for us. Hopefully you can set it up, you can share your screen. But while you're doing that too, I just want to mention to the participants out there that you can ask questions. You should have an icon down the bottom, Q&A, or the chat function there too. So please type away, ask any questions, and while we're getting through this, we'll answer those questions as we go through. Yeah. So over to you, Rebecca, if you can share your screen now.
No worries. We'll just see how this goes. So I guess we can keep it relatively informal, but I thought it'd be nice to be good just to go back through, make sure everyone's got a bit of a basic understanding of spasm and spasticity and hypertonicity, because it is quite a complex thing to understand if you don't have a background in that sort of area, and understanding can help sort of, I guess, identify sort of areas that we can help work on it. And as you said, Naz and everyone else, that sometimes there's some nice positives out of spasms and spasticity, and sometimes we can utilize that to the advantage. So I guess one of the key things that I wanted to quickly just touch on is that there are different types of spinal cord injuries, as we know, and I guess one of the key things I'm going to focus on today is that it's, you know, looking at sort of, I guess, the impacts of an incomplete spinal cord injury. Just knowing that there is, you know, about 70% of new injuries now are being diagnosed as incomplete. And that will make sense more later down the track when we're looking at where the spinal cord is injured, because sometimes it might be at the front area or the back area of the spinal cord, and depending on where your spinal cord is injured, can manifest into different things, whether it be more spasms or spasticity, whether it be motor loss or sensory loss, and so forth. So we won't brush too much on it, but there are just several types of incomplete spinal cord injuries. When we're looking at, I guess, spasticity and tone, hypertonicity and spasms, I guess it's good to understand, I guess, you know, I guess a normal basic level from what is muscle tone. So it really works on, you know, there's maintaining posture. To maintain posture, we require spinal reflex pathways to correct changes in our positioning and weight bearing. Sorry, I'm just trying to see if I can, because I can't quite see my screen. So yeah, so I guess when we're looking at what spasticity and tone is, we have a normal amount of tone in our body. So a normal tone meaning that we can activate our muscle. Low tone issues are often when, you know, you see people with the conditions like cerebral palsy and other things like that, where they don't have enough activation or activation in their muscle. And then you can have high tone issues. So it all is based on the principle of being able to have, you know, you've got a reflex arc that goes on. So that happens subconsciously and consciously. So there's the conscious control with movement, which is the cerebral activation. And then you've got coordinated intended movement, which is the cerebellar and the pyramidal tracts, which is certain tracts that go through the spinal cord. So when we have, when there's a reflex, it's typically generated by a stimulus. So a common one that we probably all know about is that sort of tendon reflex where, you know, if you hit a hammer on a tendon, your brain sends a signal to, you know, you get a signal from your muscle to say that there's been a bit of a stretch. And then from that stretch there, it feeds back into the spinal cord, and then the spinal cord initiates relief of that stretch response by activating the muscle. So there's a kick reflex that goes on. So if we think about that, that's actually happening at the spinal cord level without any cerebral control. So when we have a spinal cord injury and we lose that communication, that's one of the basic foundations of our understanding of what spasticity is that we don't have that over control of the cerebral cortex coming into play to override some of that. So that's why you often see, for an example, that a spasm or spasticity can occur when we're completing transitional movements like transfers, because your muscles will go under stretch. So there'll be a stretch response. So that stretch response will then go to your spinal cord. Say, for example, you're going from lying to sitting, your gluteal muscle will go under stretch. Your brain can't override that feedback loop that goes onto the spine, and then therefore you get this sort of mixed match control of going on, and then you can get some spasms and spasticity and increased tension in the muscle and activation in the muscle. So I guess there is some different things to understand about spasticity and spasms and hypertonicity, because they are slightly different and they present slightly differently. For example, spasticity is a form of, you know, of tone. So we can have higher levels of tone because of that, that mismatch of that feedback loop that occurs. So it's spasticity is, the definition can be a tricky one, and Andrew can probably also point this out too, that there is some still, I think probably in the literature, where we're having difficulty explaining it and measuring it. But essentially, spasticity, I like the definition. There's been later definitions, but I quite like the definition of being able to assess it as it's speed dependent. So if you'll notice that, so I don't know whether you've noticed sometimes that there is some stiffness in your muscles that occur when you move slowly, but then there's also some stiffness in your muscles. If you say you get up quickly and try and do a transitional movement quite quickly, you can get variation in your spasms. And that's because there is spasticity, which is speed dependent. So if you move a joint quickly, that stretch reflex comes on quickly, and then that's a form of spasticity. So you can get what's called clonus, which is, I don't know if anyone's had a spasticity assessment, but it's when you move the joint quickly and you stretch the muscle quickly and it gets a kickback and it beats. So that's a form of spasticity. Hypertonicity is different. It's actually, and I think arguably more debilitating in some aspects, because it's there not related to speed dependency. So it can be there whether you move fast or slow. So we often look at and assess both of those different areas when we're looking at dealing with spasms and spasticity and hypertonicity. So in terms of, so I have kind of gone through some of that, so some of the features, but essentially it leads to stiffness in the muscle, and that can lead to long-term, if not managed well, contractures and changes in the actual tendon, and also muscle atrophy as well. So some of the good things, as we spoke about, there are some benefits of spasticity. So you can use your spasms and your tone and your muscle tension to help with movements such as standing. It can help keep some muscle bulk and help preserve bone density. It's still, I would say that's still quite questionable, but there are still some evidence out there to support that. There is some downsides, and a lot of downsides, as we know, that there's difficulty, you know, with contracting the opposing muscle group. So if you've got stiffness in your bicep, it makes it very hard for you to activate your tricep to actually strengthen it and work and actually move that joint. So that's one of the key issues, is that's why you see that transfers and maintaining your position and posture in your wheelchair, it can be quite challenging. You've got difficulty with movement controls. You can get abnormal posture related to that. So if you really tighten the hips, it can help bring you forward and change your posture long term. And it helps, inhibits muscle growth and can help make things difficult in terms of hygiene and dressing and contractures. Pressure sores are another thing that can happen, particularly if you've got spasms where you're getting a lot of clonus or a lot of beating sort of rhythmic movements in your muscle activation. That, along with stiffness, can create a higher risk of pressure sore development, and also the associated pain as well that can come along with it. Look, we've briefly touched on that anyway, but what I'm trying to get at is that it is, if not managed well, it can create a bit of a vicious cycle if you do have quite high levels of high tone and high spasticity. It can be difficult to maintain function, look at transfers, and actually impact your rehab too. If you do have an incomplete injury and you can activate your muscles, having the other muscle group that has increased tension and spasticity can make it hard for you to work on that strength and access that strength and motor control. So I'll focus on, I guess, sort of what we can do as physios to assist you with working through it. But I guess one of the key things, it's dependent on your type of spinal cord injury. So that dictates what kind of, and that's why we assess each individual. We can assess looking at tone, looking at spasms, and looking at spasticity, because they can all be sort of managed slightly differently. We try and inhibit excessive tone where possible, and try and manage giving people normal sensory feedback and giving them information to their spine, because and the name escapes me now, but there's some lovely research papers coming out now that even if you do have a complete injury, they've been able to demonstrate that there is still some pathways going on from a sensory point of view. So your brain is still, your body is still getting, not your brain, sorry, your body is still getting some sensory feedback. It's just not able to send it back up to your brain. So it's one of the things I find as a physiotherapist is trying to get some sensory feedback into the muscle, whether that be stretch and movement, and trying to get some your own activation and sensory awareness in those areas is one of the key things that's quite helpful if you've got an incomplete injury. So facilitating normal movement patterns, trying to improve that motor control, as I spoke about, and it often works well if you've got lots of tone and lots of spasticity, working together with the medical professionals on, okay, all right, we're going to try and look at this. We might try and dull that spasticity down a little bit and try and activate, try and work on the opposite muscle groups, try and get some strength back into that area. And also trying to get your own active control over those muscle groups that you do have spasms and spasticity in. We also look at trying to get some, particularly for complete injuries, looking at trying to get some passive movements and some stretching, trying to help manage the secondary side effects of spasm and spasticity and tone, and as well as trying to look at posture and standing and managing in that way so we can try and limit the side effects. One of the key things that I personally find has worked well is looking at slow sustained stretching, and that's to help maintain full range of motion in the joint, help prevent further contractures and permanent muscle shortening, which are, I think, can become quite a difficult thing to manage if the contractures do develop. Particularly managing your posture and managing your positioning in your wheelchair becomes quite challenging. So we look at, what stretching does is it helps activate the muscle spindles and the Golgi tendon organs, which are sensitive to length changes, as we spoke about in that reflex arc. It inhibits or dampens the muscle contraction and tone due to the peripheral reflex effects and the brainstem reflexes that trigger spasticity. So looking at the effects of stretching, so there has been some evidence to support stretching. So we're looking at sort of, I guess, it's not just helping this one side that you're stretching, it's also helping the other side. That's one of the key things that we've found. And then as well as going on to that some passive range of movement and stretch to treat and prevent contractures has been poorly researched in my own thoughts. I do think that what they're mainly looking at here is maintaining range of movement, but we also want to improving range of movement, but we also want to look at maintaining range of movement. So look, there has been some clinical trials looking at this that has been shown to be favourable for looking at passive movements and stretching with people in spinal cord injury. We also look at one of the other techniques, if you do have some active control in your muscle. Another strategy following this is also looking at proprioceptive neuromuscular techniques, So looking at rhythm and activation together to help break down that tension in the muscle. And what I quite like to use is where you're doing a stretch and then you're getting the person to activate and then release, and that helps trick the muscle into releasing further. And that's a bit of a PNF technique. Look, I won't dwell too much on the evidence, but there has been some supporting evidence for that. Another growing body of evidence is looking at functional electrical stimulation, which has been shown to be beneficial in people with higher levels of spasticity and tone. It can help with also improving your own active control over the muscles, and giving what we were talking about is trying to get that sensory feedback into the muscle, give it something, help with sensory reorganization. So that's one of the other areas that functional electrical stimulation can also assist with. Sorry, I'm not sure if that was me or not. So look, I mean, there is still a lot of growing evidence in these areas, and I'm not here to say that this suits everyone. It's definitely person to person, but I do find that if you can explore in combination with medical management, it often can assist long-term management, because if it's not managed well in the early days, and then you're not getting on top of it, and you've got a nice chance to work on it in incomplete injuries. I'm not talking more specifically in incomplete injuries here. It can create, as you probably have all, I don't know what kind of clients we have out there, what kind of people we have out there, but I'm sure you've all experienced some of the really frustrating downsides of spasms and spasticity. And I'm sure you've had those days where it fluctuates, and some days it's really bad and really frustrating. And that's where in the early phases, if we can try and work on some strategies with you and let you know that there are options out there rather than just medical management, that there is some things to explore. And it's not for everyone. Sometimes people don't respond to these things, but what we tend to do is we do an assessment-based approach. We assess, see where the deficits are, where the main issues are. We prescribe stretches and programs based on your specific needs, and then reassess based on that to make sure it's very patient specific. Look, again, I can dwell upon all the research, but I don't think that's really the aims of today. There is also a bit more other options as well, looking at inhibitory pressures, which can help with things like standing or applying body weight. So, if you're in quadruped or kneeling postures, it can be used to promote inhibition of the quadriceps and long finger flexors, whereas sitting with the hands open and elbows extended in the upper extremity supporting body weight can help promote, inhibition of long finger flexors. So there are different positions, and that's what I'm saying. Everyone's got different patterns of spasms and sometimes varying patterns of spasms day to day, but there's usually some sort of trigger, and there's usually a pattern that's more prominent. And therefore we tend to focus on that one. Looking at weight bearing as well. So I find that this works well in combination with other strategies, particularly stretching, but looking at how to stretch through weight bearing and loading, and looking at, for example, some of our reflexes in our proprioceptive pathways can help us, we can tap into those by, for example, if we're putting more pressure in standing through the front of the foot, that can help initiate extensor patterns. So looking, if you've got like a real flexor-based type pattern, if you tend to go into real flexion and come down in your spasms, we then try and get you upright and try and get you tapping into that weight bearing into the front of the foot to try and help with the extensor activation that's in that sort of proprioceptive pathways. And then vice versa for standing as well. If you got strong extensor pathways, we try and get you more loading through that heel to try and get you more loading to come into that flexion sort of pathways. We look at body positioning as well. So helping maintain. So in my opinion, body positioning is essentially a continuation of stretching, of passive movement. It's one way we can position a joint over a long period of time and promote it to be in a lengthened position rather than a shortened position. And that's where your wheelchair scripting becomes quite important, and looking and reviewing that, but also in combination with making sure that we support you with maintaining your center of gravity skills and looking at your wheelchair skills as well in combination with that. Some rotary movements, so some rhythmical movements, looking at trying to stimulate the tonic labyrinth reflex as well can be quite helpful, and that's usually quite well done in trunk rotation and in positions where we can try and get some rotation through the trunk inside lying to help you, activate and extend. You kind of go into a sort of a bit more of an extension, abduction and external rotation pattern when that happens. And I do find that those that tend to have a real extensor pattern, breaking that through with a bit more rotation and facilitation of rotation through your trunk with a physio or a support worker or an allied health assistant can help break down some of those patterns of pathways and help give some relief. It does need to be done quite regularly, and that's probably something I probably should have touched on earlier, is that for this to be quite effective, it needs to be done as a daily thing, and it needs to be done, trying to give you some active control where you can, and if you don't, then trying to work on some active, trying to work on just progression of those stretches where possible. And then, yeah, they're the main things. And then I guess there's some bit of medical stuff, but I think I can leave to Andrew to talk about that side of things. Is there any questions so far?
There's a couple of questions coming through, but we'll get to those. Someone asked, am I able to be seen in this recording? So if you're a participant, as in if you can't see the panel, you're not recorded. So just letting people out there know about that. And also this presentation, there was a question there for you, Rebecca. Will we share, or are you able to share this presentation, or would it just be on the recording, the video recording?
More than happy to share this information. There's a lot of information in here, and I have just brushed over it just for time today. And I think today is really more trying to facilitate a discussion. And I'd love to hear some feedback and hear everyone's stories and work out. But more, yeah, I can more than happy to share that, Nans, if you want me to send a copy through.
Yeah.
It does have a bit of a breakdown and some further reading on, I guess, some of the research and evidence behind what's happening, what we're doing. And, it's not just we're just going to try this method and see if it works sort of approach. It is a measured and client-specific approach.
Right, thanks for that. Now there's some chats going on. I think for us to see the chat, it's better if people can type it out in the Q&A, and I see a few people have got their hands up. I'm not sure if they want to ask a question live. I've just replied back to a couple of people, but I haven't heard back. There is a question there. I might see if Andrew can answer this one. Mark says, I have spasms mostly during the nighttime while in bed. My body, mostly legs, start firing and jumping about. Not painful, but it does make for terrible sleeping. He's on 90 milligrams of baclofen a day and is physically active during the daytime. So during the daytime, spasms aren't an issue because he's active. So during the night, he's got some serious issues trying to sleep, it sounds like.
You want me to say something, Naz, or?
Yeah, sorry, Andrew. So if you
look,
could say
Mark
anything to that.
Something fairly classic. I think what we'd probably ask Mark is, what's the pattern of spasm through a 24-hour period? Is it worse in the morning? It commonly is. Or is it a particular time of the day when he's doing something? Is he sitting in a chair for too long, for example? At night, is he lying on an uncomfortable bed for too long? What time of the night does it happen? He's on a fair whack of baclofen. What's what timing is that baclofen been given at? One way to look at spasm is it's like a warning light. It tells you something's going up the spinal cord and setting off these reflex arcs that Rebecca talked about. So I think, is there something awry, be it, pressure sore, painful hip, back, think of anything you like that might be painful, causing the spasm to be different? I think that's the question.
Yes.
And,
So
if there's been any changes as well, if that's something that's been a long-standing thing, as Andrew was saying, sometimes it can be, if there's a change, it could be even like an ingrown toenail or something that's giving the body some stimulus that something's not quite right, out of the ordinary. And sometimes it can even be as simple as like more heat, like if you've got some sweat issues and that sort of thing, if the blankets are too hot or restrictive, that can be enough as well to work through it. So yeah, it's almost kind of like, in some ways, you know, if you've ever had autonomic dysreflexia and there's triggers for autonomic dysreflexia, it's kind of the same sort of triggers on a low grade. It might not be, you know, the full symptoms, but there's something triggering the system to say something's not right here, and that can be an output of more spasms.
Yes.
Rebecca, just wondering, have we gone through the presentation? Just wondering if we stop sharing the screen and come back to it.
Sure, we can definitely do that.
Maybe after answering a few questions.
Sure.
Oh, excellent. Thanks for that. We can see each other again.
That's nice.
So, yeah, it seems like it's a troubleshooting situation. No, he did say he's taking 90 mils of baclofen during the day. I don't know if there is an option to break it up and, you know, maybe take some of it at night before he goes to bed. He may be doing that. So maybe it's something he's got to consult with his GP a little bit more and try to troubleshoot some of that.
And a common one is, you know, a common complaint of spasms. And we think about spasms, you know, I still think is quite different to, you know, your tone, your higher stiffness. It's a different presentation altogether. And it's often a tricky thing to manage, but it can sometimes be that, you know, your body's been in one position for too long. It needs a change in position. And sometimes it's a matter of having a routine of, I'm going to spend a few hours in this position. I'm going to then move to a different position to promote a bit more movement, because we know particularly if it's quite okay during the day and so therefore the movements, it's responding well to movement, that sometimes some change in positions overnight and some structured change in positions overnight can be helpful. But also it's like sometimes it's what you're doing before bed to help promote some fatigue in the muscle too. So, you know, it might be doing a stand before bed or stretching before bed to help give some of that feedback into those muscle groups to help them relax for the evening, in combination with making sure that the medical management side of things is optimized.
Excellent, thanks for that. Here's another question. Helen and Ben are asking, they're interested in exercise movements for incomplete SCI when brittle bones is also at risk. So I think the question is, they're probably worried about, you know, doing too much activity in case they have issues with their brittle bones.
Okay. Yeah. I mean, there's always a screening that we do if you're looking at activity. I mean, it's more the risk is if you're doing lots of load bearing, like standing, and you haven't done that for several years, then yes, there is a risk, and you need to go through and have a chat with your physiotherapist or occupational therapist about going through the risk profile and making sure that that's measured in the regime. But there's plenty of ways to still do activity in not, such load-bearing positions, and still activating those muscle groups. So there's always a way to work through, I guess, depending on the risk factor of your bone density.
Thanks for that. Just on that spasm question that we had earlier, Mark continues saying his spasms are every day. His legs jump about a fair bit during the day, but nothing crazy. At night, however, his legs almost require strapping down. Without pillows and heavy blankets around his legs, his kneecaps trying to meet his chin, so he's trying to knee himself, I guess. So again, it depends on finding a solution with maybe his medication. Does he need to change the medication throughout the day and have different medication at night? I'm not sure if you wanted to add anything to that, Andrew, or well, I'll say Andrew. Andrew, sorry, you've put yourself on mute. We couldn't hear that.
Yeah, too many phone calls. Look, I think the bone fragility question is a very major one, and it's a totally separate discussion, but very important. Medications are not simple for spasticity. They're all aimed to dull down the reflex arcs, and that's the baclofen that's been described. I don't like it. It's a pretty tricky drug to deal with. It's got a very narrow window of operation. So the difference between 40 and 100 is a lot. I mean, 100 milligrams a day is quite a lot, and it can make people quite flat. And other things can go on. The other drug that's come out of the States we're using a little bit now is called tizanidine, which I think some people might have heard of, and it works on extensive spasm mainly, but it seems to work well. And it's a drug we're trying out, has less sedation than baclofen. The other thing is that this is usually a painful stimulus, so sometimes even painkillers can help reduce the sort of the spasticity. Now, when you get into the really heavy stuff, we're starting to talk pumps. You know, the pumps themselves, and I think you mentioned someone else, they can be incredibly useful because you're getting micrograms or thousandths of a gram rather than grams of the drug being used. And it's directed directly to the spinal cord. But they're 20 grand a pop. They have to be refilled. The batteries last 6.5 years. They can erode through the skin. They can get infected. So they're kind of in our. I know other people are more cavalier about this, but we sort of hold them for people that have really uncontrolled spasm. If that makes sense.
No, that's great. We touched on baclofen pump, and I mean, medication is always helpful when you need it. You know, I mean, it's not like a first thing to jump onto if you've got issues. I think you've got to try different medications, and you know, there's steps to follow as well.
Yeah, and I would say an adjunct, as what Andrew's saying, there's a lot of side effects that go on to the medication, and it's not by any means a cure for it. It's a damping down, and you often have a lot of side effects of that damping down of those systems long term. I think I'd probably suggest maybe going through, you know, what's the 24 hours for this person, and what are they doing for activity during the day? Are they giving their body a chance to actually, you know, get some sensory input into those areas? So whether it be tactile, you know, with standing, or whether it would be, you know, looking at stretches, you know, if they've got some active movement, trying to get some active movement in those muscle groups where possible. And then, you know, looking at trying to see what they're doing in preparation for their sleep hygiene overnight. And it might even be, as Andrew was saying, it could even be as simple as the mattress might be a bit too firm or too soft. Often there's got to try and find a middle ground for it. So there's so many factors to go through, and there's so many small things that could be looked at. But I think one of the key things I would suggest is that what this is for this person over a 24-hour period, and make sure it's very specific to them. So it's a bit hard to put like a, you know, you do this in this situation. It needs to be sort of go through the history, you know, look at, it could even be something like there's a contracture in the muscle if they've got spasticity and tone, and there's a contracture going on, and the position they're laying themselves in is, you know, is not prompting that, because if a joint is contracted, if a muscle is contracted, whether we stretch it or not, it's not going to change that amount of contracture. So if they've got a contracture and they're trying to put their body in or a joint in a position that doesn't want to go and won't go, that's going to give a painful response, but they can't feel that. They can't feel that stretch response. It's an issue. The stretch response, that's just one example of what could be potentially going on. And there's multiple examples of what could be going on, but it needs to be looked in a very a structured way. You look at all the different areas when addressing it.
Thanks, Rebecca. I think you broke up a little bit, but I think we got the main gist of your answer there. I'm going to try something new. We've got a guy, I'm going to bring him on to ask a live question because he's having trouble typing. Ellen, if you're there, I'm just allowing you to talk. So if you've got your microphone off, please ask away. A couple of questions you've got there. And there's quite a few questions coming out in the chat too. So Ellen, if you're there, speak away. If you're not ready for any questions, I want to run through some of these questions. So have you got a question, Ellen?
Yeah, hello. Yep. hear
Yeah,
me?
go ahead.
Okay. Do you want roughly my profile of my condition, or?
Oh, look, if you can be quick.
Yeah. I'm an old quad, incomplete quad, August 77, and 1977. Yeah, and I'm incomplete, but I seem to be struggling with a lot of things. I've had a few different operations and stuff. And when I went through, there was Valium as a thing for controlling spasm, and baclofen was just sort of coming on the scene. And I've noticed my spasms getting worse, but each time I've had the last operation I had, I was off my feet 3 months and stuff. So it was hard always to bounce back. And my spasms are mainly in bed of a night, my legs shaking and trying to walk. I can't keep my balance. It's sort of restricting me more and more and more as lately. For my balance and everything, I have to be sort of led around by the hand. And I was in control of my balance a lot better prior to some operation. I had a rebuild on my shoulder, and I had a couple of bad infections, and I was in hospital 3 months, and it just sort of all mucked me spasm routine up. And I'm really getting bad constipation. And when I get a spasm in my stomach, it makes me go, really loud. And I seen a doctor in Geelong, and she reckons that the pain-killing drug I was on, they'd have to put me back on it and reduce it down slowly. I can't remember what it was now, but yeah, they gave it to me when I had the infection in the Geelong hospital, Melbourne hospital there. And I'm a bit of a mess at the moment. I can't work out how to go about getting back on cue a bit better. I've gone numb under my feet for some reason, under my good foot.
Alan, thanks for that question. But pretty much we know the situation. So your spasm's getting worse and it's causing other issues as well. Could be the medication, but I think I just wanted to hand this over to Andrew. But good to say that you are trying to problem solve with your GP, and that's the best starting point.
Well, my GP doesn't really know much about spinal at all, and being from Ballarat, it's really difficult to find accurate help,
Yeah. Well, what we might do, we might send you, I might send you an email just with some links. But Andrew or Rebecca, did you want to answer that quickly? Because I want to move on to our other guests to talk about their experiences.
Fair
Just quickly, I think am I on mute or not? No. Look, one of the other hidden bones a problem. The other problem that we don't really manage that well and don't understand particularly well is bowels. If you look at the average abdominal X-ray of people who come to the clinic, they are often very full. And if you think about you carrying around two or three milk cartons of extra load and it's stretching your bowel, it will drive spasticity. And I think that we forget about it, but it's quite important. And it's not easy. It's very hard to manage bowels. I think we undermanage them, and probably the first thing I'd be doing is checking out whether you've got a full bowel. I'd be checking out whether your hips and back are okay, for example. One of the other things I just mentioned, I don't want to go running off getting worried about it, but post-traumatic syrinx is a well-recognised problem in the spinal cord, and it can cause increased pain or spasticity, and sometimes it can cause you to lose your motor level. So, there's many things there that, but common things occur commonly.
Thanks, Andrew.
I would probably agree with what Andrew's saying there as well. Probably just, Alan, just that the sensory changes is probably something, as Andrew was saying, sometimes those signs can be particularly a reduction in sensory feedback, you've got to ask maybe why you've got a bit of a change in your activation of your muscles and your feeling in your legs. It would be a change of condition, and I would probably definitely check in with your GP and get a full screen again and just make sure everything's going okay. But in terms of, I agree with what Andrew's saying with the bowel side of thing. One of the biggest things I see when there's an increase in muscle tone and spasms, my first question is always the bowels, because it is commonly to do with bowels. If you haven't gone to the toilet well for the last couple of days, you know, the bowels seem to me to be the common denominator a lot of the time. And some key things that you can help with, if you don't have any activation in your legs, some passive cycling of the legs or stretches, or some movement, you know, looking at those stretching and movement, you're going to help with that motility of your bowels. Even if you can't do it yourself, having someone there working through that with you can really help with bowel management.
Great, thanks for that. Now, this one's to Emily, Josh, or Geoff. Got a question here about the best leg stretches to relieve muscle tone and spasticity for paraplegic. It'll be the same for quadriplegic, I'd say, as well. For example, hamstring, glutes, groin, and pushbacks. So I know a lot of us guys have got like tight muscles. Well, what sort of treatments or exercises do we recommend, or have we found that works for us?
Well, my physio, which was Beck, put together a stretchy routine, which I do every day, and it goes stretching different leg muscles, and I actually made a video of it and put it on YouTube, going through the different stretches. So I can give you that link so you can watch at a later date to see what stretches I do that help me.
Thanks, Emily.
To Rebecca's point, Naz, I think just staying, you know, physically active. I find, say, the days or more so a weekend, if I haven't gone out, you know, just pushing or exercising, my spasms are much more aggravated. So when I do jump into bed, and I guess if I was to jump into bed, I might, you know, since I have that functional capacity, roll onto my tummy and just stretch out to those hip flexors. I find that seems to be my trigger. And then, you know, the standing frame is always good as well. Like, you know, I'll be honest, I've got a bit lazy with it, using it, but I definitely find that a good one if my spasms, and to Andrew's point, the pain. So the tighter my spasms are, I think it heightens my pain. So when I have a lower back or other pain coming on, I definitely find stretching helps both those.
No, thanks for that. Now, this is a question about baclofen. Someone asked, does baclofen tablets affect memory, and what's a long-term diagnostics or diagnosis? I'm not sure if anyone takes baclofen on the panel here.
I took it for about 3 years, Naz, and then the thing that annoyed me, and we can ask Andrew and Rebecca to speak to this a bit more, but I found with the interim when I took the tablets, I was close to 100 as well. So I take it, and then like the hour leading up to my next tablet, I found my spasms were, you know, worse or more increased. But again, this, I guess my function early on, or, you know, my strength and balance in a chair was, you know, building. But I found, yeah, very just tired. And then if I missed my nighttime tablet, I was wired. I wouldn't be able to fall asleep. And that sort of being addicted to it sort of just really annoyed me. But yeah, I'd be interested in the panel's thoughts.
For me, I wasn't taking a huge dose of baclofen, but I was taking it in the early days, and I felt like it didn't make a big enough difference for me. And what I'd found, that it made me really cloudy in the head and not really with it and being able to do all the things that I wanted to do. So for me, I decided I didn't want to take baclofen. But for other people it works, but for me, I didn't like the effects it had on me.
And actually, no, if I can, just a quick takeaway, just especially for those guys at Rehab, if they are listening, it's like, I think early on baclofen, like Emily mentioned, was probably, you know, beneficial because my spasms probably put me at danger with transfers. So there's that risk reward balance, just to, you know, not to be anti-baclofen and that stuff. Yeah.
Good. There's a question here. Does anyone have any experience with positioning systems like those for postural innovation, and do they help?
Yeah, I can probably answer that one a little bit. It depends. It's person to person, and it really depends on, is your primary issue contractures? Are you years down the track and you've developed contractures, and therefore you need support in positions that you can't maintain yourself in bed or overnight. And as I was saying to you about that sort of passive stretching positioning being a continuation of passive stretch. So trying to help with that elongation of the muscles and maintaining that length in the muscles. So positioning systems can work well, particularly I find they work well if you've got really high tone. So if it's not so much spasms and it's more like your legs are so stiff and heavy is just a word people describe because it's hard to feel stiffness. But if your legs feel really heavy and they're hard to position in bed, sometimes some supports, and it doesn't need to be so aggressive positioning. It could be something as small as a pillow between your legs to help with the alignment of your hips. So you can start very small, but I do find it does help for those that have quite higher levels of tone and spasticity sometimes. But spasms, it can sometimes be caused more of an issue because you're constantly spasming. And therefore it's probably looking at more what you're doing before you go to bed. As Josh was saying, when he's not very active, he tends to be more prone to increased stiffness and spasms. So it's looking at what you're doing during the day in preparation for your sleep. It's not, my sleep's the worst thing. It's looking over that 24-hour period of what you're doing beforehand. That's really the key thing in my opinion.
Great, thanks for that. We've got quite a few questions coming through, so I'll try to get through some of these quickly. This one's like a comment and a bit of a question as well from Colin. He tried baclofen after 10 years on diazepam, developed back pain caused by lack of tone, went back on diazepam for the last 25 years without problems. However, his hip contractures limited his hip rotation now. Could this be because of the lack of medication? He's only on 5 milligram BD. That's a technical one for me. I haven't got the answer.
I don't know if you want to go with that one, Andrew, or
Oh, probably not. Anyway,
Yeah.
look, I think it's complicated. What Rebecca talked about was contractures, and the hip's very prone to get a flexion contracture, but particularly if you seated a lot of the time. And therefore, it leads to early degenerative changes in the hip, and that's a stimulus for spasticity. Baclofen might be useful to stretch them out, but I don't think it's the panacea by any means. You'd probably, in fact, consider botox now if you deal with that particular problem, if it's localized. But the first thing is look at the mechanics of what you're doing, which Rebecca can talk about.
He's made a comment further saying he's a C5-6 quadriplegic for the last 45 years and has osteoporosis for the last 10, and he's scared of stretching.
Okay. Yeah, I mean, I would probably agree with what Andrew's saying. I think it's less to do with medical management and more to do with what's happening day to day. And it's one of those things that's really hard to, I guess, if you're early on in your rehab phase, it's really hard to think about the long-term effects of, okay, we want to look at it might be seem something like mundane, that like, okay, we want you to be in this position overnight to help maintain the length of your muscles, or we want you to spend some time out of your wheelchair rather than being in it, for 12 hours. We want you to spend some time being out of the wheelchair, laying on your stomach, or trying different positions where possible so that you can help promote muscle activation and muscle stretch. It's hard for people to see that in the early days. And so I think it's probably just really important to touch base with your physio or your OT about that. And it's never too late to start addressing the issue either. So, even if you have low bone density and you're worried about your, the fracture risk that poses that, it's depending on your degree of spasms and spasticity and tone, some light stretching is reasonably safe if done well and assessed previously. If you've got someone trained in that area and knows how to assess it and knows how to, and Emily can probably bang on about this, on how much I hone in on the importance of actually feeling the person doing the stretches, feeling their way through it. And with that, you can complete quite a safe program.
Thanks for that. Geoff, just wanted to go to you. I know we just talked about different types of medication and what issues we've got with spasm and how you've dealt with that. Do you want to just talk about your experiences?
Yeah, I pretty much, I tried a lot of different things when I first got out of the spinal unit. I went through the New Zealand one at Burwood in Christchurch, and they taught me some really good habits, as in doing regular pressure relief to avoid pressure sores. And I've, for the last probably 15 years or so, I've had standing wheelchairs, Levo standing chairs, and I stand up just about every hour and weight bear, maybe every 2 hours sometimes. But if I try to stand up too quickly, I can often go into a full-on spasm. But if I just sort of gradually work my way up, then they're not a problem. And at night time, I try to stay off my backside because I've been sitting on it for much of the day. So I always sleep with my hips twisted right off my bum, and which leaves a bit of a problem that I can get sore shoulders, but I usually twist off the bony bits of my shoulder, and I can just about sleep the whole night in that position. It's a bit of a strange position, but I find if I try to sleep on my back, then I do get woken up by my legs jumping. But if I sleep on my side, I don't have any problem most of the time. And I do stretches every day that I don't have a shower. But just basic stretches. I used to go on a full-on regime of stretches, but I found it was taking up so much of my day. I just got lazy in the end, and I stick to basically hamstring stretches, some rotations around my hip just to keep the hip range of movement going, and some calf rotations, just keep the ankle joint moving. And I have a powered X and Flex machine, which I strap my feet into, and it sort of cycles my legs around, which was interesting to hear that could be good for my bowels. That's good. But I just thought it was good to get a bit of blood circulation, and I've got a Saratoga cycle that I strap my hand splints onto, and I cycle away for half an hour when I, probably 3 or 4 times a week. And I find that that's enough to keep me sort of maintained. If I don't stand or do some kind of pressure relief, I do start to notice that I'm feeling uncomfortable, and I think that's just my body telling me that I need to do something. And other than that, my body's stayed in pretty good nick. I haven't had any pressure sores or anything like that. I don't have too much trouble from spasm. I just have to watch out on the motorized chair that if I am getting more spasm one day than another or something like that, I have to be careful that my hand doesn't sort of lock on and drive me into something. So put it into slow mode when I'm going down narrow corridors or by people or whatever. You certainly learn to manage.
Great, thanks, Geoff. Just wondering if anyone has tried dry needling or cupping for spasm control. These questions come up, or other than medication, are they options, and has anyone tried it?
I did acupuncture numbers early on, and there's probably some benefits there. And I definitely find after I go to the osteo, I have a massage. It definitely helps with my spasm and I guess the pain management. Sorry, I think someone else is going to mention something as well.
No, continue.
That was the
that was you. Okay, sorry.
I think I interrupted someone as well.
Yeah. So I guess the question was there any solutions other than medication or injections.
Well,
Rebecca-
that ask Naz, if I can, actually, just to Andrew, if that's all right. Because
Yeah.
you did touch on Botox, Andrew, and then I'd be interested to speak maybe a little bit further to that, and I guess the evolution, and if you do advocate that, and also maybe your thoughts on medical marijuana. Is that a treatment for spasms? And again, a bit of an overview, if you don't mind, if it's used.
I was waiting for the last one. Look, in terms of the muscle end plates, the muscle end plates get activated pretty dramatically in this sort of situation. So all the things Rebecca's been talking about to deactivate the muscle and make it relax are important. Dry needling just simply hits the end plate and causes it to sort of relax. It's a bit like exaggerated PNF that she was talking about, and we can stretch out a calf pretty well doing that. Botox is the next step up. It tends to, as you know, it's an antibody and it goes straight to the motor end plate and knocks off the muscle sort of ability to contract, and lasts for a period of time, 3-6 months. The problem with the stuff is that you can only give a certain dose per every 6 months, and it's become a particular problem for some people because they often their bladder being treated with Botox as well. So it seems to be just for one area, not for the generalised treatment. Medical marijuana. Where's Ben? He's in the background somewhere, but I'm sorry his name. Look, I think it's something that we're very keen to explore. Pain. There's enormous concern about pain being treated with marijuana because it's like OxyContin. You become addicted to the stuff, and you could potentially have some side effects. So there's a little bit of worry about that. Spasm's a little bit purer because the physios can measure it very nicely, as Rebecca said, with speed and stuff. You can use dynamometers to measure it. You can measure it all sorts of ways. So we want to run a trial. In fact, we were going to run a trial for COVID on people like yourselves outside the hospital with a very clear, a double-blind trial of using this stuff. So because the Canadians suggest, anecdotal people say it works, but the Canadians are suggesting that it might, but no one's ever done a proper trial because everybody's a little bit different. So the way you do it is you basically either give people the drug or not the drug, see what happens. Then you have what they call a washout period, and then you start the drug or not the drug, and you can get an idea whether it works or not. Maybe next year.
Yeah, that'd be good to find out more about that. But I know medical marijuana is becoming something a lot more people are trying. And we actually had a webinar on this a few months back. So people are interested to know more about that, go to our YouTube channel and you can watch that webinar.
There is also, sorry, just touching base on trials, there is a trial actually taking intake now for November, December, looking at stimulation over the muscles and doing some walking, overground walking, and that's something that can be if you're interested. They're looking at people with incomplete spinal cord injuries at this point in time, but if that's something you're interested in and interested in exploring in the trial, let me know when I can put you in touch with someone.
If I could just say something about the medical marijuana, as I just did a 3-month trial with the TAC to approve me, to approve them funding me medical marijuana or CBD oil for the rest of my life, I guess. And so I did the pen spasm frequency scale, forgot the other one. I did a brief pain inventory, also the modified Ashworth scale. So for me, it was very singular to me. And what I found is over the 3 months, it didn't stop spasm, like dead in its tracks. It took away the height of the spasm. So the pain, it would take away the real pain that I got from spasm. I'm on 140 milligrams of baclofen. I'm on 5 milligrams of diazepam. And so that was the kind of hard thing to justify, was if I was off those drugs and I was just on CBD oil, the difference. So 3 months wasn't long enough, but I found that medical marijuana or the CBD oil for me just took the height of the spasm away. So I would still get the same shakes. I would still get it was the same spasm, but it took away from the pain. That's what I found. Sorry, that was my 2 cents.
No, very good. Thanks, Alex, because a lot of people want to know about that too. I mentioned our webinar on medical marijuana and a lot of other subjects on our YouTube channel. Josh thankfully put the link on the chat. So if people are wondering what that is or where that is, just have a look in the chat and you'll see the link. Emily, question for you. Someone mentioned about using spasm for their advantage. You know, this person had a heavy spasm that's settled down now, so it's nearly non-existent until they're doing their spasm. So can we just ask or go around how we can use spasm to our advantage?
Well, for me, it's more learning how to use how my body works with my spasms. So, for example, if my legs are doing extensor, like going straight, and I want them to come in, pressing underneath my top of my thigh under the knee, near the knee, pressing there kind of relaxes it so I can bring it in. So it's about learning how your own body works and what trigger points or what parts you can, you know, where to grab. So it makes it easier and use it to your advantage. But yeah, that's for me.
Thanks, Emily. I know, Josh, you use spasms to your advantage as well. Do you want to just speak to that?
Yeah, you know, like I think over time, Naz, you learn to, you know, live with the spinal cord injury and learn how, I guess, it works for you. So, you know, to Emily's point, you know, when you're putting pants on, you can spasm at the legs straight so the chinos get on quicker, or, you know, when you're transferring from the bed, it gives you a bit of stability. Like I can lean into it so I can get, you know, that better transfer. Or even, you know, if I'm transferring into, you know, a mate's car to tie up, I can use those spasms to help once I get that angle to extend and almost sort of jump, or, you know, use that as like a platform to then leverage myself. So there's different ways to go about it. Do you have any tricks for yourself, Naz, how you use them?
Again, sometimes, I mean, everyone's different, aren't they? I know when I'm moving, like when it comes to transfers again, I feel them building up, and I know how they're going to affect my body. So I know if it's going to push me back or lift me up a little bit. So I try to time my spasm with my transfer, and I find that really helpful. And I think lots of other people do that as well. But on the other, a lot of people find spasm dangerous. Like if you're pushing or going down a path and it's pretty bumpy, it sets your spasms off, you know. So you get back spasm, which, you know, could chuck you out of your chair backwards or go sideways or whatever. I think a lot of people could feel that coming on, and you sort of try to react before that happens. You know, you brace yourself or whatever.
And guys, if I can just add, just they touched on it earlier on, both Andrew and Rebecca, just understanding there can be a trigger for other things, like something like a pressure area, or, you know, if you're sitting on something that you shouldn't be, or, you know, just there's a whole myriad of things, but learning to maybe pay attention to maybe what's causing that, and then keeping that for future reference.
Yeah, particularly if there's been a change in it, if a change in your pattern of your spasms, that would be probably a key thing to have a think, go through everything. But yeah, just something about sort of transfers as well, because I know that's a key issue for a lot of people with spasms. But sometimes a key thing, and it sounds very simple, but changing the speed that you do something. So if we look back at that mechanism of spasticity, a lot of people are trying to get their balance, so they rush it. And that stretch reflex, if you rush it and you stretch the muscle fast, you're more likely to spasm. So it's sometimes just going slow and a bit more measured and controlled can actually help with that as well. And I guess looking back at some of the other things that can be helpful for more to do with tone, so not spasticity, but or spasms, but tone. So tone can be helpful for, managing activation. So, Geoff, if you were saying that you're doing some standing, if you've got, tone, the muscles can stay active and on and stop from giving way. And Emily, when you were looking at doing some recent new adventures with your standing, if you didn't have some muscle tone in there, you would drop down. So there are some benefits for transfers and transitional movements if you can use them well and change your technique to work in with those spasms and tone.
No, great. I've got a comment here from Helen. She says, believe it or not, we have found a small dose of ibuprofen works best to relax muscle spasms. So that's something that they found really helpful. Sarah also talked about, I think we've touched on this as well. She asked, does anyone on the panel have any tips what they do to get through spasms or minimize them or even stop them, especially at night? Her arms and hands jump around each night quite badly. They'll eventually stop, but sometimes it can take hours. So we did answer that question. Was there anything anyone wanted to add to that?
I sometimes put, or I often at night put magnesium cream on just to help. It just helps calm down a little bit. And I've also noticed during the day that my breath can have an impact on my spasms. So for example, if I'm yawning or if I'm, my breath's not calm, I spasm. So if I feel a spasm going to come on, I try and really slow down my breathing, and and that it helps a little bit. Yeah.
Yeah, no, that's great. Got another comment here from getting through these pretty
I might just have to run off, guys. I'm sorry, but I have to go. But thank you so much for having me on here. I appreciate the time. And if you've got any more questions, feel free to reach out. But sorry, I do have to run, unfortunately.
No, Rebecca, thanks so much for your time.
Thanks, everyone. Bye.
And you've got a comment here. This is not a question, but Helen's saying we need more bowel experts who understand SCI. Her son has megacolon now requiring fleet enema every day. So that's just a comment there.
I might just throw, Naz, while you're reading through some of the questions to Andrew, and it sort of plays to Sarah's comment. Andrew, have you found sensory to be quite a trigger for a lot of spasms? Like you mentioned, I guess, the bed they're laying on. Can they use like a, what do you call it, like a lamb's wool to maybe lay on to inhibit those reactions?
Yeah, all that stuff. And in fact, some people find vibration helps because it confuses the sensory pathways. So, I think there's many, one of the problems we have in anything, not just spinal cord injury, is that everybody's different. So it's a matter of people working out, having the information and trying out things that work themselves.
And so to that vibration, would that just be like it's something you just go to Bunnings and get like the what's the name one, or is that like
a Zuto vibrator sandpaper? I think it probably work, but no, look, like you can buy vibrating plates for your feet.
Yep. Okay.
Look, I suck it and see, mate. I don't think everybody's the same.
Yeah, no, that's right. I think we touched on the question by Duke. He asked, are there any new technologies that can help with spasm management or elimination? That was Duke's question. Just seeing if there's, I really appreciate your time, Andrew. I know you're a really busy person. I'm just trying to see if there's any other questions.
By the way, Naz, your thing was dropping, your thing was closing down, and you have to I don't know whether you've run out of time on your webinar. I hope everybody's still there. You're right. Okay. Yeah.
Should be.
Just make a comment in terms of what Duke wanted to know about. Look, I think Susan Harkimer's work, which I think is what Rebecca was talking about stimulating the spinal cord, might well have some great benefits in the future. So that's all being explored at the moment.
Yeah, no, good. Thanks for that. Someone asked a question. Their spasms have reduced and aren't that bad now, and they're taking baclofen still. So, question is, can they stop taking that medication, or do they have to slowly stop decreasing it?
Yeah, well, good question. I think that any medication, my view of the thing is any medication you should occasionally, gradually reduce it and see if you get a worsening of symptoms, be it pregabalin or baclofen. Baclofen you've got to be particularly careful of because you can have too much and have side effects. But if you suddenly stop it, you'll certainly get side effects, which I think maybe is what Josh was telling us. So just be aware you've got to go on and off it pretty slowly.
Yeah, I think that's a good point to make. Everyone needs to know that you can't just get off something because you need to find out the consequences of that first. 3 more comments here, and I think I might just invite everyone else into the room if they want to have a chat. John, sorry, John, I know you put your hand up before, but wasn't able to get to you. But comment is, I've been on baclofen since his spinal cord injury in '84. Reduced the dose to 75 milligrams and still getting spasm, but it's controlled. I'd be interested in trying the new medication that Andrew, you just mentioned. I don't know which medication that was.
Tizanidine.
Okay.
It has to be got through Canberra. It's called a Form B. Just needs to be ordered.
So just start the discussion with your GP, Andrew. That's the best way.
Yeah, and the GP won't know anything about it. So what'll happen is they'll then contact the Austin.
Okay.
That's what we do.
Okay.
Is there like a link or something we can share with everyone's attended today in our follow-up email, Andrew? Or
look, it's a drug that's not used in Australia as a standard drug.
Yeah.
Okay, cool. It's Tizanidine, T-I-Z-A, I-D-I-N-E, Tizanidine. And I don't know how the politics of this works, but the Austin has to sort of order it specially. It's very common in the US.
One question here, Rebecca's left us, but Duke also asked, do you need to be assessed by a neurotherapist to set up a benchmark to change to see if there is degradation or improvement by therapies? I guess the answer to that would be yes. They'd be able to do the test for you before and after. Alan Clark, says, are spasms and spasticity the same as cramps? I had an incomplete spinal cord injury about 2.5 years ago. I can walk reasonably well, and I was still undergoing physio to strengthen both upper and lower body. I get quite severe cramps, especially at night, and always in both the hamstrings and lower leg. I use a product called Cramp Peas, but still get the cramps. Is there a medication that would be more suitable to stop these? I think we've gone over that as well.
Naz, look, the answer to the question is, it could be quite different. I mean, particularly if you're incomplete in walking, you could be getting cramps for other reasons. I mean, obviously the commonest treatment of cramps is using magnesium.
Magnesium.
Yeah, in the real world, yeah.
Great, thanks for that. I think we've covered most of the questions. What I might do before we open the room to everyone, does anyone want to just share a takeaway message? Josh, start with you. You're on my screen, top left.
Maybe, this, from my own personal experiences, I found spasms, quite, what's the right word, debilitating, couldn't transfer, all that sort of stuff. But I guess just a little takeaway that for the ones at rehab or still new to spinal cord injury, I guess it's a process that you work through. And I definitely have found to use them to my benefit and learn to live with them, Naz.
Thanks, Josh. Very good. Emily, how about you? Any take-home messages?
Yeah, sure. So what you probably learnt from this is that everyone's different. So what works for someone won't work for someone else. So you've got to find what works for you. And so I recommend writing, like in a book, just writing some notes about your spasms and things you notice. And like, if you're trying something new, write some notes how that works. And then so you can compare it to something else you try. Makes it easier to figure out what works best for you.
Great advice, Emily. Excellent. And Geoff, any final words from you?
Oh, just that, as I said, I've never taken any medication for them. I always looked at them as, you know, somewhat positive thing. It keeps my muscles from wasting away, and it can be annoying sometimes, but you know, you just get used to it, and sometimes it can be useful. If, as you know, as mentioned, if your body is trying to tell you something and you have a spasm, it can save you from getting other problems, you know.
And you and others as well mentioned weight bearing. I think that's coming out as well. Weight bearing, putting pressure on your joints. I think that reduces spasms for many people. Andrew, any take-home messages from you?
I think Geoff made a very good point. This is a symptom. It's not a, it can be caused by many different things, and it can be useful or not useful. So the most important thing is to do what I think Emily was talking about. Get a daily diary and see, you know, when you get it, make sure you take your back within 6 hours. That one's out after 6 hours. You know, check the relationship between all those different things that are going on, and you might find there's something in particular you can fix. That's
right. You don't have to see a doctor or a GP for everything. You know, you can keep track of what's working and what's not. I think that's really good point. Alex, any final advice from you?
Yeah, basically just agree with Emily, Geoff, and what Andrew said. Yeah, well, definitely agreeing with what Andrew said in regard to it being a symptom of other things. I myself have kidney stones. I can't get them removed due to other complications, but that being a cause for that little bit of pain and things like that causes me to have extensive spasm. But just always keeping an eye on everything. So keeping an eye on, well, doing a lot of stretching. I found stretching to be really good, and always just keeping an eye on your health. You got to be extra vigilant as a person with a spinal cord injury, because we do suffer from paralysis and we can't see and know everything that's going on in our body. That, you know, we do have to stay that bit more vigilant than able-bodied individuals and things like that. But keep an eye on your health, keep an eye on your body and how everything is going, and you know, that's all you can really do. Especially
thanks very much, Alex. Great. I've got a lot of comments here saying thanks, guys. A lot of people appreciate what we've discussed. So what I'm going to do, Andrew, I want to thank you especially for joining us late notice. It's great having you on here from medical background. Emily, Josh, Geoff, and Alex, yeah, thanks very much.